Good evening and welcome to the Minnesota Ovarian Cancer Alliance's virtual Living Well meeting on treatment advances. I'm Stephanie Gliniani, MOCA's Community Support Program Manager. We're glad so many of you have joined us tonight. We have quite a virtual crowd. During this presentation, we're going to explore some of the latest ovarian cancer treatment options and discuss clinical trials. First, I have a couple important reminders for everyone. We have a handout available for you to use during the program. Just click on the handout tab and download a copy and follow along with us. We're expecting that a lot of you might have questions for our guest speaker tonight. You can submit them through your chat box or email us at info@mnovarian.org. We will do our best to get to all of your questions. Now it's time to welcome our guest speaker, Dr. Andrea Wahner Hendrickson of Mayo Clinic. Dr. Wahner Hendrickson is a clinician and researcher with a special interest in developing new treatments for ovarian cancer. We are so delighted and grateful that you've taken the time to be with us this evening and share your expertise. Welcome, Dr. Wahner Hendrickson.
Thank you, Stephanie. It's so nice to be here. I wish we were all kind of in a room together, being able to chat in person so I can see your faces, but sadly I can't. But this is the next best thing, so I'm happy to chat with you. I'm really excited tonight because I think there are a lot of great kind of upcoming treatments and a lot of really, advances that I think are wonderful. So I can't wait to chat about those.
We are so delighted and thankful for you to be with us. So thank you again. And now it's time to turn over our presentation to Dr. Wahner Hendrickson of Mayo Clinic. And thank you again for being here with us. And I will see you for the Q&A.
Thank you. Hopefully you guys can see my screen okay. I'm playing with it a little bit. So it's a lot to cover, and I think that's the good news, is that there's too much to cover in this short period of time. But the goals that I have in terms of what I want to cover today is I want to touch briefly on maintenance therapy. I know this is something that many of you are going through or have gone through. There have been some changes and updates which are exciting, and so I want to just talk about that a little bit. And so that's with the use of PARP inhibitors, a class of drugs that we'll chat about, and also another agent called Avastin, which kind of targets blood vessel growth. Both of these can be used as maintenance therapies, and talk a little bit about that. And then I want to talk about some really, exciting treatments that are currently in clinical trials. Some of these involve immunotherapy, so kind of modulating our own immune systems to fight the cancer. Some of them are targeted therapies, so really kind of getting more into personalized medicine and really tailoring our treatment to some changes that are in your, or this specific tumor. And then I want to make sure I leave a lot of time for questions. These are things that I like to talk about, but maybe you would like to talk about other things as well. And so that's where I'll make sure that we leave time for plenty of questions. So I first want to touch on maintenance therapy. What is maintenance therapy? How do we use it? And so when we think about maintenance therapy, when we go through our ovarian cancer treatment, what's really kind of changed in the past 5 years or so is really the importance of maintenance therapy. For most women, the initial treatment is a combination of a surgery and a chemotherapy. But then there's a period of time where your physician or your team kind of said, well, now we're going to kind of watch and wait. And so in that space now, we do have options for kind of a treatment that really helps control or prevent the cancer from coming back. And so the benefit is it may help the cancer from coming back. So you're doing something during the time which used to be observation, and it also could potentially slow cancer growth. The disadvantages of maintenance therapy is this would have been a time when you may not have been on treatment. So, you would have been away from the clinic a little bit more. And so whenever there is a treatment, even though the side effects in general tend to be a little bit less than what we kind of think of standard chemotherapy, but there still are side effects. It can be costly in terms of time and money. It is more visits to see us, which not everybody is excited about. And some of these are newer, and so we're still learning about some of the long-term side effects. So for the maintenance therapies for ovarian cancer, we really have two biggies. One is a class of drugs called PARP inhibitors, and I'll go through that in a little more detail. And the other is a drug that's been around a little bit longer, and it's a drug called bevacizumab. That's a very odd name, and so the drug name is Avastin. And in some situations, we even combine both of these. So there are 3 FDA-approved PARP inhibitors, Lynparza, Rubraca, Zejula. And so kind of depending on your specific scenario, perhaps your insurance coverage, perhaps some of the side effects that you experience during chemotherapy, your team may recommend one over the other. They're all essentially, in terms of outcomes, we think they can be, used essentially the same. And so the actual drug doesn't matter as much as kind of this whole class of drugs. So I'm just going to talk about them as a whole. What is the benefit of using this? These are all oral agents. 2 of these are given twice a day. One of them is taken once a day. So what is the benefit of taking this? I mean, you probably just went through chemotherapy. Now we're talking about adding another treatment. And the benefit of these drugs really varies based on the genetic makeup of your tumor. And so, it's not perfect. We're still learning about how best to kind of get a feel of how well your specific tumor will respond to these drugs. But in general, what we see is if your tumor has a BRCA mutation, these are really sensitive to this class of drugs. And so we really see quite significant improvements in progression-free survival, or time it takes for the cancer to come back if it were to come back. So we can see benefits of, a year and such when we, or more, when we add this as an oral medication after you're done with the chemotherapy. There's kind of a middle ground, which is called HR deficient. This is, and we'll talk about this a little bit more in a bit, but essentially if your tumor shows signs that it can't repair DNA well, there's something wrong with that pathway, there are, pieces missing, then we see that this drug tends to work better than if the tumor really shows all the signs of a really good DNA repair pathway. And that's called HR proficient, and we'll go through that. And so how do you know, what your tumor is, what it looks like, at least on these tests? Does your tumor fall in the BRCA, HR deficient group? Does it fall in the, HR proficient group? How do we figure this out? And so that's really, it depends on the genetics. And so, BRCA1 and BRCA2 are genes that you probably have heard of because they are linked to, increased risk of breast and ovarian cancer. These are mutations in the DNA repair pathway. Like I had mentioned, these PARP inhibitors are especially beneficial in this because these mutations lead to defective DNA repair. Now you can develop, or your tumor can develop this in 2 different ways. One can be germline, meaning it's inherited. So it's in all of the cells in your blood. It's something that can be passed on from generation to generation. A somatic mutation means it's in the tumor only. So the tumor, these cells continue to mutate and change with time. And so it could be that your tumor has a BRCA mutation, but it's not present in your blood, it's not inherited. And so to really assess that, we have to kind of look in 2 different ways. We know that this pathway has multiple different genes involved, and so it's not just BRCA. There are other types of changes and patterns that we look for, and that's done by tumor testing. And so I do recommend you chat with your oncologist and your oncology team about, was my tumor tested? What were those results? And if it hasn't been tested, could we test that? So let's just talk briefly about genetic testing. So please remember that everybody with a diagnosis of ovarian cancer should get genetic testing. So that's really, we want everybody to get genetic testing. And when we talk about genetic testing, we definitely, honestly, I would recommend that we do both the blood and the tumor testing, but at minimum, the blood testing. So the blood testing or saliva test is a test that looks at inherited changes. And so there's a panel of tests that we definitely, recommend that all women with ovarian cancer undergo this testing to see if there are any of those changes, because that also gives us information regarding family members and whether their risk of ovarian cancer is high. And there are things that can be done to monitor and to ensure that other family members are closely watched, because of that risk of ovarian cancer. The other thing, like we had talked about earlier, is we would also want to do somatic testing or test the tumor itself, because maybe, there aren't any mutations or changes in the cells that were tested in your blood or your saliva that are inherited, but maybe the tumor just had a sporadic change and now it does have some defects in that DNA repair pathway that makes it more sensitive to PARP inhibitors. And so both of these tests are really helpful when you think about, do I want to go on a maintenance therapy, and what is the benefit for me? And so I think, the exciting thing about this is our treatment's becoming a little bit more personalized. We can get some information from your tumor and from your genetics to really kind of figure out what makes the most sense for you. So when you get these results, they might say, you have a BRCA mutation or a specific mutation, and that can be germline or somatic, so it could be inherited or through the tumor itself. They may give you something back that says you're HRD positive or HRD negative. And what does that mean? So HRD, homologous recombination deficiency, really essentially what it means is if you're HRD positive, there are some changes in that DNA repair pathway that makes your tumor more sensitive to the PARP inhibitors. So the benefit in terms of how long it would take for the cancer to come back, if it's going to come back, is longer than if your tumor is HRD negative, meaning there is not a defect in that HR pathway. And so, I think this does require, a pretty significant conversation with your team about what those results mean for you, because it's unfortunately not black and white. We know the testing isn't perfect. We know that, we have seen that even in this HR deficient group, where we would expect the PARP inhibitors to not work as well, sometimes we do see responses. And so sometimes this test is not enough. Sometimes we look at, how rapid did the tumor shrink with the chemotherapy? Are there signs that maybe, this test isn't perfect and we still want to do the PARP inhibitor? With the understanding that maybe it won't work as well as it will in someone that has a BRCA mutation, but there still may be significant benefits. So it's really important to talk to your team about what is the benefit to me. And so it does vary, and it also kind of, we can get a little bit more of an idea also kind of depending on how, things went with the chemotherapy. Another term that you might see is genomic instability. So if your oncologist says there's a lot of genomic instability, it suggests that you're more likely, the tumor is more likely to kind of respond to that PARP treatment. So, but what about that Avastin? We had talked about the Avastin. There could be, several of you out there that have gotten Avastin with the chemotherapy. This maintenance therapy with Avastin is a little bit different because the PARP inhibitors we start it after you're done with the chemotherapy. The Avastin, we start with the chemotherapy and then continue moving it on afterwards. There's some, benefits to Avastin. And again, it's a discussion kind of held with your oncologist about the pros and cons of using it with initial treatment or recurrent treatment or both. But there is also the option, let's say that the Avastin was started with your chemotherapy, that you can still continue on a PARP inhibitor. So it's not mutually exclusive. We do find that the benefit really seems to be in those that have a BRCA mutation or have that change in the pathway. There isn't a change in the pathway. We see that the Avastin is enough. We don't necessarily need to add a PARP inhibitor to improve outcomes. So again, it's hard when you kind of speak to a general group, but these are things that you should talk to your oncologist about and that are very personalized, kind of depending on your symptoms, what other medical conditions you have, whether or not we can add these on. And these can be added on initially, so after your initial treatment, and that's really where we're moving the PARP inhibitors, is we like to use it up front, so kind of with your initial treatment. But some people, these weren't around when you were initially diagnosed, and so we've moved, maybe the cancer has recurred, and you can use it in a recurrent setting. And so it does have multiple time points where we can use it, but in general, we use it if if your drug or if your tumor is still sensitive to a drug called carboplatin. The other question that often happens is, well, okay, so I started this maintenance therapy, I started this PARP inhibitor, how long do I have to be on this? Is this something that's going to just go on forever? And honestly, it varies by situation. So part of it depends on the side effects. This is a period of time where, before this class of drugs was approved, it would be a time where you would not be on a treatment. And so if you're having a lot of side effects from this treatment, I think it's really important to talk to your team about that, because we can modify the doses, and we've shown, and the studies have kind of shown that it's not a one size fit all. If you think it's, these are oral medications, we all come in different shapes and sizes, so it makes sense that people need different doses. And so it is okay to modify the doses, be on lower doses, that's okay. But if even, despite that, there are significant complications, it's important to stop it. And so it might depend on, the side effects. The other thing is disease. If the cancer comes back, we want to stop it. We want to shift gears, and we want to try something different. And so it could be that it's stopped because there are signs that the cancer is coming back. It also kind of depends on when we use it. In the upfront setting, in general, we tend to use it about 2 years as kind of a maintenance therapy for about 2 years. One trial looked at it 3 years, but that's really kind of the window that we're talking about. When it comes back, so let's say, you didn't get this maintenance therapy with the initial diagnosis, the cancer came back, you were treated with the carboplatin and something else, things worked, responded well, and now you start on that maintenance therapy. In those trials, it was kind of until the disease came back. So there were people who were on it for years and years and years. And so it does also require a discussion with your team. Because there is some debate as to, in those scenarios, do we still stop at 2 years, or maybe we continue like they did in the trials? So some of it depends on how you're tolerating it, what your blood counts look like, how you're feeling, but so again, this is also sometimes just something that really just needs to be discussed with your clinical team. And like I had mentioned, in one trial, they used 3 years versus 2 years. So all of those things have to come into play to decide how long you would be on this medication. So in general, it's pretty well tolerated. I mean, compared to some of the chemotherapy regimens that I know that, you guys are familiar with, it's pretty well tolerated. They all have similar side effects. Again, it does require, personalization and tailoring the dose to fit, you and that. But in general, it's mainly fatigue, some appetite changes, some nausea, unfortunately, that we can work on. But the thing that I think people need to be aware of, and the risk is relatively low, but it needs to at least be on everybody's radar, is that because if you think about how these work, these are working by damaging DNA. But unfortunately, it can damage the DNA in our bone marrow, and our bone marrow is where we make our red blood cells, our white blood cells, our platelets. So it can cause some dysfunction. It can cause kind of that your body isn't able to make platelets, or as many platelets, or as many neutrophils, and so that can be difficult if we want to treat with chemotherapy down the road. Can also cause a blood cancer. Again, it's rare. It can range it's still a little debated, kind of for between 1 and 6 to 8%. So this can happen. And so we do need to be aware, and that's where the discussion of how long do we stay on it also is important. And there are, interestingly, some tests that we now are doing here at Mayo, kind of evaluating, you know, your bone marrow ahead of time to assess if you potentially might be at higher risk for developing some of these blood disorders. So it's really, again, important to talk to your physician as to which one may work best for you. Remember that everybody responds to treatments differently, and there's not a right answer for everybody. I should also explain that these are really, so far, have really been used in situations where the cancer has really spread outside of the ovary. And so in what we call earlier stage cancers, where it's really confined to the ovary, we aren't really using these yet. You know, it's not part of the FDA indication because the chances of cure with chemotherapy alone are high. I don't know if eventually, you know, that it will be kind of moved, and could we potentially someday use these medications instead of subjecting everybody to you know, to chemotherapy? That's a hope. We'll see where things kind of move forward in that standpoint. So my parting thoughts about this: there are some great, you know, new maintenance options. They can be used as a treatment as well. So if there's, you know, some concern that the cancer is coming back, we can sometimes use this before starting kind of the standard IV chemotherapy. It can be used with Avastin, like we had briefly talked about. And really, it's important to just talk to your team about, does this make sense for me? Where do I kind of fall on the spectrum of how beneficial it will be? So what I want to move to now is kind of some of these newer therapies that are in clinical trials or have completed clinical trials, and we just don't have all of the results yet. So I think these are some options that I'm super excited about, and so I can't wait to talk to you about these. And I think a question that arises for many people is, you know, clinical trials. When do I think about clinical trials? And is clinical trials really only for people where they've tried a million things, and so now we're just going to try clinical trials? That's not how I think about clinical trials. I really think we should think about clinical trials at every stage, right? You know, and sometimes there are opportunities at every stage, and sometimes they're not. But the only way we move the treatment for ovarian cancer forward is by you know, trying these new treatments and moving these new treatments forward. You know, the PARP inhibitors were just in clinical trials a few years ago, and now they're FDA approved, and that's because so many wonderful women, you know, signed up for these clinical trials, tried these therapies. And so I really do encourage you to talk about, you know, potential clinical trial options. Your team will be honest with you about, does it make sense for you now? Or is standard treatment, does that make more sense? And I'm very, you know, when I meet with people to talk about clinical trial options versus not, and I say, which one would you do? I would tell you, you know, which I think makes the most sense. But it is definitely worth talking to your team about, well, are there any clinical trials? And do you think that makes more sense, you know, based on my tumor genetics or histology or whatever it is? Or do you think we should do the standard chemotherapy? So it's definitely important to think about all the time. And so what I wanted to talk about are some treatments that are currently in clinical trials. Some of them are very close, kind of in the phase 3 trial. So these are trials that are hopefully going to lead to FDA approval. So these are right on the cusp of what might be available even outside of clinical trials soon. So I know, you know, that what is interesting for most people is there's a lot of discussion about immunotherapy and can I use immunotherapy, and where do we stand with immunotherapy with ovarian cancer? So immunotherapy, just briefly, it's really trying to harness your own immune system to kill the tumor. So making your own immune system do all of the work. So it's really showed a lot of promise in many different tumor types. The goal is to boost your natural immune system so it works harder, it works smarter, and it kills the tumor itself. And so that's really an exciting way of treating the tumor. And in general, it often, not always, but seems to have kind of a better, you know, side effect profile. I don't know why this is, there we go. So, you know, immunotherapy has made the news a lot. It's been really, it's moved in some tumor types forward much faster than in others. Kind of the standard immunotherapy, you've probably seen commercials for like Keytruda, unfortunately hasn't been as I guess as promising as it has in other tumor types for ovarian cancer. There is a subtype that we do think responds really well. These are kind of a specific change in the tumor. Again, we get this information by tumor testing. And so it could be that your tumor may have a profile that we think it is more effective. This is often or more likely seen in like the clear cell carcinoma. That's a type of an ovarian cancer, or a mucinous. But if there are those changes in your tumor, it could be that kind of the standard or the Keytruda type of immunotherapy may be an option. What we're really looking at is, what if we combine it with something? Maybe then the beneficial, maybe then the benefit will be more. And maybe we just need to identify which tumors are going to benefit the most from immunotherapy. And so right now there is a lot of interest in combination therapy for ovarian cancer. And so there are clinical trials available that are looking at kind of that standard immunotherapy, whether it be Keytruda or one of those similar, and maybe combining it with Avastin, or combining it with PARP inhibitors, combining it with another immunotherapy agent, or even with chemotherapy. There are also new ways to target the immune system that also seem really promising. So one trial that is available, and it's available at the University of Minnesota and at Mayo Clinic, is called this NanoOvary study. And so what it does is it is looking at pembrolizumab, which is Keytruda, and really trying to see what subtype, if there's a subtype that is more likely going to respond to this treatment. So we believe that there's a specific profile that would lead to an enhanced response or a better response to this immunotherapy. So what happens is we test your tumor. If the tumor has that specific profile, which is only in about 10% of ovarian cancers, but if it has that specific profile, then we use the Keytruda. With immunotherapy, you have to, when you think about how it works, is it kind of overstimulates your immune system. So if you do have a significant autoimmune disorder that requires steroids, then this is not a good option, because it would kind of also enhance your autoimmune disorder. But otherwise, it's IV. It's given every 3 weeks. The catch is the tumor has to be tested first and has to meet the specific profile. This is a phase 2 clinical trial, meaning it's kind of gone through the first selection step. It looks like it's safe. It looks like there's some hint of efficacy, and now it's in a kind of a phase 2 process. Phase 3, those are usually the ones that are really designed with the FDA that lead to FDA approval. So in this study, everybody who has this profile does get the treatment. And again, it's open at the University of Minnesota and at Mayo Clinic. What's interesting is this trial, it's called the FLORA 5 trial. This is a trial that looks at a new way of enhancing the immune system, a drug called Oregovomab. It's very hard to say, but what it does is it binds to CA125, and you may have heard of CA125 as something that ovarian cancers tend to secrete. So the ovarian cancers to enroll have to secrete this protein, but it binds it and it induces an immune response. And so this is a phase 3 clinical trial, meaning this is going, hopefully, it's being evaluated for FDA approval. We don't know the results yet, but that's what this trial is looking for. The catch with phase 3 clinical trials, when you think about clinical trials, a phase 3 clinical trial is trying to prove that the treatment is better than what we have currently. So in order to really assess that, half the people have to get the standard treatment, or the treatment you would get if you were not on clinical trial, and half the people get the treatment that we're testing. So if you sign up for this trial, it may be that you get randomized to the arm that gets the standard treatment. So you still get the standard treatment like if you didn't go on the trial. It's not like you get placebo, but you don't get the study drug. So half the people get this, and half of the people get this, the combination. And so this is for patients and individuals who are recently diagnosed, because this is with upfront treatment, the treatment with carboplatin and paclitaxel. And so half the people will get the carboplatin and paclitaxel, and half the people will get the carboplatin paclitaxel plus this drug. It is not open at Mayo, but I do see that it is open through Minnesota Oncology, and I think Dr. Pepin Thomas is kind of leading that. And so, this is really only for new diagnosis right now, but I think we're all excited to see if this might be a potential treatment that can be used in other situations as well in the future. I'm having some struggles here with advancing slides. Here we go. Okay, so what about, let's see, yep, okay, I'm sorry. All right, so another approach for kind of enhancing the immune system is using viruses. And so at Mayo, this is an interest of ours, is kind of how can we harness viral therapy to treat ovarian cancer and other cancers. And so this is using the thought that infections can result in an anti-tumor effect. We have seen that. So sometimes people will have an infection, we see an enhanced anti-tumor effect. And so with this measles virus strain, we have seen that adding this has slowed down tumor growth in mice. And we do know that ovarian cancer cells, interestingly, overexpress the measles virus receptor. So what this study is looking at, we have two of them actually. One of them is a phase 2 clinical trial where you're randomized, kind of like we had talked about before, where you would either be treated with an FDA-approved, chemotherapy, so what you would have done if you were not enrolled in a clinical trial, versus doing kind of this monthly infusion of this virus. The way that this is done is you actually get a port in your abdomen, and the viral therapy is infused into that port. And so in order to enroll, the cancer really has to be confined to this abdominal cavity, and it would be reviewed by the team to ensure that's the case. So that gets infused there. So half the people will get that, and half the people get standard chemotherapy. Another treatment, or using kind of this similar approach, is a different study. It's another phase 2 study, but in this one, everybody gets the viral treatment. But what we're doing is, you're eventually with the other treatment, we are wondering if we can actually enhance the amount of virus that can make it to the ovarian cancer cells if we hide the virus. So what we do is we take out some of the fat cells from your abdominal, from kind of your abdomen here, and we hide the virus in the fat cells, and then that gets infused in. And the hope is that maybe with this approach, we can even get a higher volume of virus to those tumor cells. And so this is also a therapy or a trial that's going on. These are both open only at Mayo Clinic, but these are options for you as well. And so next I want to talk about, like I had said, these are some phase 3 clinical trials that are really exciting and kind of a targeted therapy approach. And so one is targeting the folate receptor alpha. Some of you may be familiar with this, as we've had other kind of targeting treatment approaches at Mayo looking at this marker. This is a drug called mirvetuximab. I'm super excited about this drug. The clinical trial that we have available now is called MIRASOL. It's open at Minnesota Oncology and at Mayo. It's a national trial. It's a phase 3 study, and we're looking at for women who have tumors that have high expression of folate receptor alpha. So it's something that we would test on your tumor. We can use this drug, and so what it is it targets the folate receptor on your ovarian cancer, but to it is attached a drug. And so it's a drug that in a sense is a little bit like Taxol, but instead of it kind of being diffused throughout your body, I mean it still is, but it really targets the tumor cells. So the folate receptor drags that drug right into the tumor cells. And so this is an IV infusion once every 3 weeks. Again, because it's a phase 3 study and we want to prove that it's better than the standard chemotherapy. Again, we don't know. We're waiting for these, we have to wait until this trial is done. You're either randomized to standard chemotherapy, and that is a discussion with you and your oncologist. So your team would pick out what drug you would use if you didn't go on the clinical trial, and then you would sign up for the clinical trial, and then they tell you you were randomized to the mirvetuximab, this experimental drug, versus the chemotherapy that you had already picked out. So this is available at multiple sites in Minnesota, which is exciting. So whichever is closest to you, I think this is a good treatment option. And there's another targeted therapy that I'm very excited about. This is the AXL pathway. So the AXL pathway is a pathway that we're learning a lot more about, and it seems to really be playing a role in kind of the tumor cells growing. And so AXL, or accelerate, is the name of the study. This infusion really kind of shuts down that pathway and hopefully prevents the tumor cells from expanding and growing. Again, the phase 2 clinical trials looked promising, and so this is a phase 3 clinical trial. So again, it's a randomized trial. What they have found is it seems to work really well in combination with paclitaxel. So I know that most of you have, gone through paclitaxel treatment up front with initial diagnosis, but we can use it again, and we often use it again. And it's given on a weekly basis. So this study, you're either randomized to the weekly Taxol infusions or the weekly Taxol plus this new agent. This one is also available at 2 sites. It's available at Mayo Clinic and then in St. Louis Park, according to a website that I looked at. And so I think it is definitely, I'm excited about this agent. I'm excited about all these agents, but I think it's worth looking into. I would say, as you probably know, paclitaxel can cause that neuropathy or the numbness and tingling of hands and feet. And so if that's a significant side effect that you're struggling with, this might not be the best option, because in both cases you're going to get more of that Taxol. What I wanted to touch on briefly, which is also, I think, pretty exciting, is a completely different approach. And so this is called Tumor Treating Fields. I don't know if you've seen this. This is a mechanism that's already FDA approved for brain tumors, but this is something that is now being looked at other tumor types. So what it is it's actually a localized treatment. And so you're given these pads that you put on your body here, and what it does is it sounds very science fiction-y, but it actually induces kind of these electrical currents, these low wave electrical currents. And what it does is actually those cancer cells that are trying to divide, it kind of messes up their ability to divide in a correct fashion. And so it's been proven to be effective in glioblastoma or very aggressive brain tumor. And so now it's being evaluated in ovarian cancer. It's something you wear. The side effects, you don't have the nausea and such of kind of standard chemotherapy. It is worn most of the day. You get like a backpack with a battery pack. They're getting smaller. This is an older picture, but it is it's a different approach. It's an exciting approach. It was in a phase 3 clinical trial, which has already closed to accrual, meaning everybody has accrued, and now we're just waiting for the data. So hopefully we'll find out and see if this will be a treatment option in the future. It is given with weekly paclitaxel again, because that is also a drug that kind of interferes with the cell's ability to divide. And so it is given in combination with chemotherapy, but I think it's a kind of an exciting and different approach. And so hopefully we'll hear about the results of this within a year or so. So fingers crossed that this might also be an option. So I know I want to keep time for questions, so I don't want to keep talking. But I think, or what I hope that I was able to display is that, the time of kind of treating everybody exactly the same is no longer there. everybody's cancer is different. Everybody is different. You know, their body is different. What their, you know, the side effects are different. And so it is, you know, cancer treatment is very individualized. And so you might be talking to people and their course is very different than yours, or the treatments are very different than yours. And I think that's a great sign. It means that we're able to really kind of think about each tumor a little bit differently. What's going to work best? What's going to work best for your body? And so I think this is exciting. It's going to continue to be more and more individualized. So I think it's really important to establish a good relationship with your oncology team to really be able to talk about all of the options, to ask questions, to see which one makes the most sense for you. And also, don't forget about clinical trials. I think that's really important. It also, you know, gives you so many more options for treatments. And as you can see, a lot of these have a lot of promise. And so please consider clinical trials. That's where we get all of our new treatments. And so I'm really excited that we're going to continue to see new FDA approvals of drugs in the next few years. And so I'm very hopeful about kind of where things are going. And so I hope that I was able to share with you that we are in, you know, in the team of physicians that are taking care of you. We're really excited about these options and are very hopeful. So I want to thank you all for listening to me ramble on for so long. My kids would be very impressed that you guys have not left or logged off, or maybe you all have. But I'm here to take any questions, happy to chat about, you know, things that weren't clear or other things you guys want to talk about.
Amazing. Thank you. Thank you so much, Dr. Wahner Hendrickson. I mean, this was just such an amazing presentation, and we've heard that there are new treatments available and new options that we can explore, and we just appreciate you so much for sharing your expertise. I do want to say we do have some questions that have come through, but if you have not submitted your questions, you can use the chat feature and send your message to the organizer, or you can email us at info@mnovarian.org. And just please know we're not able to answer any specific medical questions, but we're happy to answer questions. So let's just jump right into it because we already have a few. So the first one, should genetic testing be repeated after a certain amount of time to capture any updates to understanding how genetics really determine our cancers?
That is a brilliant question. That is a great question. So the answer is probably, you know, I think it kind of depends. You know, if your tumor testing was done, you know, several years ago, you know, these panels are continuously updated. I think it is worth talking to your team again about redoing it. You know, some of these, you know, your tumor also continues to change. So there could be things that were present before that are no longer present, or vice versa. So, you know, I wouldn't say that one has to do it, you know, every time there's a change, but I think kind of depending on when the initial testing was, it is definitely worth talking about whether or not it should be repeated.
Perfect, thank you. The next question, do you have any information on the success of any of the immunotherapy trials?
Yes, so, you know, I mean, not the ones that are ongoing. So, you know, part of how clinical trials work is when they are ongoing, we don't get, you know, very clear. I mean, there are safety analyses that are done with a group of individuals to make sure that if there are signs that it is not working as well, that the trial shuts down. So for example, there was a clinical trial looking at upfront, you know, carboplatin paclitaxel plus that drug Keytruda. And so there was a clinical trial that kind of looked at that. It looked like it was not helpful, and so it did shut down early. So there have been some clinical trials with immunotherapy, unfortunately, in ovarian cancer that have not shown benefit. But I think what we're doing now is we're getting smarter about what to combine it with. I think we were excited at the beginning and we were just saying, well, let's just combine it with our standard chemo. Now we understand that maybe, you know, there is scientific rationale to combination with, you know, with Avastin or combination with PARP inhibitors, or kind of like I was talked about, you know, and in we have a kind of an early cancer therapeutics clinic here that is not, you know, these trials are not necessarily specific to ovarian cancer, but there are several trials that are taking a second approach. So we're using kind of that standard immunotherapy, and then we're adding a different type to enhance it. And, you know, anecdotally, we've seen some nice responses with a few of the people with ovarian cancer that we have put onto these trials. So I do think there's still hope with immunotherapy. There was a lot of hype. Then there was like kind of a pullback, like, oh, maybe this isn't going to work at all in ovary. I don't think that is the case. We're still trying to tweak and figure out exactly how it's going to work best.
Perfect. Thank you. So next question. I've seen some reports that the diabetic drug metformin has some effects on ovarian cancer. Can you report on what that is about?
Yes. And so, you know, this is a topic near and dear to my heart because I was very excited about the initial data of using metformin in combination. So initially this came from some kind of population-based studies where we noticed that women who had diabetes and were on metformin seemed to do better if they developed ovarian cancer than those that were not. This is, you know, kind of an epidemiology study. So this is, you know, kind of just a population-based study. So we didn't really know why. In the lab, it did look like it might alter the metabolism or maybe even change kind of the microbiome or kind of the bacteria in your body that we now realize also plays a role in how your body responds to cancer. So at Mayo, in combination with the University of Chicago, we started a clinical trial. We had a clinical trial open that looked at, you know, with your initial diagnosis, getting your surgery, the carboplatin and the paclitaxel, and then adding metformin. And so we were very excited about this. Unfortunately, we didn't see a benefit in our trial. We have not published it yet because we're still working on kind of the final analysis. But unfortunately, we were really disappointed to see, at least in the group that we tested in, despite, you know, the promising initial information, we did not see a benefit with adding it.
Okay. Well, thank you for that information. That is appreciated. Next question, are there any promising treatments for platinum-resistant ovarian cancer?
Yes.
I know that's a big thing, obviously, platinum-resistant, so.
Yeah, and I guess I apologize. I should have been more clear. So most, you know, those targeted therapies that I was talking about, the mirvetuximab, the AXL drug, the tumor treating fields, all of those were in platinum resistant ovarian cancer. You know, as you know, and for those of you who are not quite familiar with these terms yet, you know, right now we think the best drug that we have for ovarian cancer is carboplatin. So we kind of define when we think about ovarian cancer, is it's still kind of sensitive to that drug, and you could argue maybe, you know, PARP, you know, that class is still sensitive to those, or has something in the tumor changed where really we need to focus on other treatments. And so, you know, honestly, there are probably right now, at least here at Mayo, there are more trials for platinum-resistant ovarian cancer than platinum-sensitive. It's a little bit harder to get traction for clinical trials in platinum-sensitive disease because we don't want to move away from using the platinum. So right now we have more trials actually available for platinum-resistant disease. I think all of these look really promising. I agree it's an area that, you know, we are definitely working on, but all of those trials that I had, actually every trial that I had mentioned is available for platinum-resistant disease.
Okay. Great. Thank you so much, Dr. Wahner Hendrickson. So next question, to what degree do clinical trials apply to low-grade ovarian cancer?
Wonderful question. So low-grade ovarian cancer has a different biology. And so, you know, when you think of your diagnosis, there's kind of high grade and low grade. The low grade is slower growing. And because it's slower growing, some of our standard chemotherapy options don't work as well, because when we think about, in general, how does chemotherapy kind of work? It's really trying to kill those cells when they're dividing, because that's when our cells are most sensitive. And so the low grades grow slower, and so some of these standard chemotherapy options don't work as well. But there are different pathways in low grade serous that are targetable. And so in low-grade serous, we do have targeted therapies like hormone therapies, MEK inhibitors is kind of a mutation, KRAS. And so we do actually have low-grade ovarian cancer specific clinical trials available at Mayo. happy to, connect at some point somehow to kind of talk about those if that's something you're interested in. But yes, I think what's hard is that many of the trials that I have discussed exclude low-grade serous, but we do have others. I chose to kind of talk about more of the higher grade trials because it's more common, but we do have low-grade trials available.
Okay, that's great. Thank you for that information. And we can get people information too if you reach out to us afterwards. If there's something more specific, we'd be happy to get you that information. So thank you for that. So is there a specific stage or qualification for ovarian cancer that kind of qualifies for these treatments, and how do you figure that out and go about making sure you qualify for these?
Yeah, that's a great question. So, I think when we think about stage, it can be kind of confusing because when we think about your stage, when we as the cancer team think about it, we think about what that means when you were initially diagnosed. So when you're initially diagnosed and you meet with your team, they will kind of tell you what stage it is, the grade, and that kind of sticks on your documentation throughout, your entire journey. Up front, the big difference is the cutoff is kind of stage 1 versus others. If the tumor is really just confined to the ovary, in some cases we don't need chemo. In most cases we still need chemo, but oftentimes that initial scenario, you're kind of excluded from some of the clinical trials, and that's because your outcomes are good. If we can just get, through some of that chemotherapy, hopefully, it's curative. I mean, we hope all of these are curative, but in that scenario, these trials are not an option. If the cancer comes back ever, right? Regardless if you were stage 1 when you were diagnosed, or you were stage 3, or you were stage 4, if the cancer comes back, all of these trials are options for you. You'll still sometimes see in your notes, you're still marked down as, kind of as you go through the records at some point, it says stage 1. But we kind of use that staging up front, and then we kind of transition to the word like recurrent. And then if you have recurrent cancer, all of these are options. I hope that was
that was great. I know. And these are these can be tricky too. So, and I'm going to probably pronounce this wrong, but ivermectin, is that okay? Yeah. Someone has been hearing about that and wondering if you have any thoughts about that as treatment for ovarian cancer.
Yes. So that is a drug. Oh, sorry.
Yeah, can you say that correctly for me?
Oh yeah, ivermectin.
Ivermectin, okay, perfect, thank you.
So that is a drug that has had some interest in terms of, can this have some, kind of cancer fighting abilities. We do not have enough data at this point that really proves that it is. It is a drug that also has a significant amount of side effects. So the way that it is metabolized is really hard on your liver. And so that is a drug that we also have to be careful about in terms of tolerability and ability. It also can cause some very horrible diarrhea. But and so it is a drug that has been, it's made the news a lot in terms of also, could this play a role in COVID and other things? So it is a drug that's being investigated, but right now we don't have enough data to show that it's an effective treatment option for ovarian cancer.
Okay, great, thank you so much. So you might have touched a little bit about this on the genetic testing, but if someone has had a recurrence, should you recheck your tumor after recurrence?
Yeah, that's a great question. So,
okay.
When we think about the tumor testing, I think it is important because in some cases, let's say you were diagnosed with a very early stage where, for example, you don't need tumor testing in terms of PARP because we wouldn't use it. It might be that your tumor hasn't undergone that whole genetic testing. So I think at the time of a recurrence, it's definitely important to talk to your team about saying, hey, was my tumor ever tested? And if not, definitely get it tested. If it was tested, kind of looking at how long ago was that? Did I have, any treatments in between? You know, some of those factors play a role as to whether it's important to retest or not. In some situations, I would say, yes, we probably should retest. In other situations, I would say we don't need to. It really kind of depends on exactly what's going on and what your treatment options are at that time to see if it would make sense.
Okay, wonderful. We have had a lot of questions coming in, so we might not get to all of them. I will just do one more question before we kind of wrap things up. But if someone is on a PARP inhibitor and things have changed, is it appropriate to go back on a PARP inhibitor at a different time? If or when is it appropriate to go back on a PARP inhibitor, the same one or a different one, if you have any thoughts?
Yes, that is the million-dollar question. So whoever asked that question, they're spot on, right? This is a huge question that we're wrestling with. So, you know, the bottom line is we're not 100% sure. There is new data suggesting maybe using a PARP again could eke out a little more benefit. So that's exciting. What I would say is that it kind of depends on the scenario, right? So, you know, in some cases, let's say you were diagnosed, you were on PARP for 2 years, you recur at year 3, definitely I'd say we reuse it, you know, use it, you know, maybe do chemo again, reuse it. If there is rapid, you know, changes while you're on the PARP inhibitor, I am less excited about reusing it because most, you know, most of them act kind of in a similar fashion, but we are getting more data about that. There are trials kind of that are just coming out looking at, you know, what is the benefit of PARP after PARP? I think part of it depends on how you respond to the chemotherapy in between. But that is a great question that we are all kind of wrestling with. So it's a little, again, I feel like I say this all the time, it's kind of an individualized decision, kind of depending on what, you know, what happened when you were on that originally, but it's not completely ruled out.
Okay, wonderful. And that will just lead to more discussion as we find more information out. And so we, MOCA and myself can't thank you enough, Dr. Wahner Hendrickson, for being here with us tonight. We really appreciate all your insight and your expertise. And so I just want to thank you so much for this amazing discussion because it's so important for our community. So thank you, and I do want to thank all of those who have joined us in the audience. So I will say bye to Dr. Wahner Hendrickson. I do have a couple notes before we end the session tonight, but thank you for being with us. So before we close out, I just have a couple things. If you are new to MOCA and you're looking for support, please reach out to us at info@mnovarian.org or our website at mnovarian.org. We have bi-monthly support groups, a MOCA mentor program, MOCA Cares Kit, and other several resources. We are here to support survivors and their families throughout their journeys with ovarian cancer. Another key part of MOCA's mission, as you have partly heard tonight, is ovarian cancer research. This year, we will be awarding $1.1 million to ovarian cancer research projects, and that is the largest amount ever awarded in a single year. So I would like to invite you all to MOCA's annual meeting, May 24th, starting at 6:30 p.m. at the Wilder Foundation in St. Paul. During this meeting, we will be presenting our 2022 Research Awards, and this is always such an exciting night because you will hear from the researchers themselves about their innovative projects, and we will also honor and celebrate our MOCA board transitions. This meeting is free and open to the public, and you can learn more and register at mnovarian.org. If you've missed a portion of tonight's Living Well meeting or would like to watch again, we will be posting a recording at mnovarian.org, and this will also be available on MOCA's YouTube channel. One final reminder, if you are with us live tonight, you should see a survey pop up on your screen after you close out the session. Please take a moment to answer a few brief questions about your experience. We greatly appreciate your comments and feedback, and I thank you everyone, and have a great night.